Hi there, I'm Nikki Ayozie. I'm an MPH candidate for the public health program with the University of Florida, and I'm here with Allison White.
Hi, I'm Allison White, and I am a PharmD, and I'm a pharmacy resident at PCHC.
And today we're going to be talking about hepatitis C in our program, Demystifying Hepatitis C, Empowering Primary Care Providers. We have no disclosures, and this class is accredited by the CCPM. The importance of today's topic is hepatitis C is prevalent throughout our community in Maine. And in the United States, over 50% of people are unaware that they have this infection. So it's pretty common and easily transmittable. That translates to about 1% of the US, which is 2.4 million Americans, and then 15,000 Mainers. Hep C contributes to 40% of chronic liver disease and is the leading cause of liver transplant. And the WHO has a goal of eradicating Hep C and other infectious diseases by 2030. The United States is not on track at this point, so we have a lot of work that we can do. And here we have a graphic of the state of Maine and showing the density of the most cases of chronic Hep C on the dark blue in Penobscot, and then we have the highest concentration of cases down in Cumberland County. And specifically for CCPM, about 1 in 5 of those people diagnosed with hepatitis C are treated for Hep C, so only about 19-20%. And this is pretty low compared to those with private insurance. Typically, 1 in 3 receive treatment within a year of diagnosis, and 1 in 4 of those on Medicare and Medicaid. So we have some work that we can do with treating Hep C in our area. And then next, our learning objectives are here. So we're going to go into these topics, explaining and describing chronic Hep C as a health issue, employing screening guidelines and diagnostic criteria, recommending treatment for simplified cases and when to refer out to specialties, and reviewing sample hepatitis treatment protocol in primary care settings. So we're going to go into public health perspective of chronic hepatitis C. So with public health, we sometimes use systems thinking. So thinking more broadly with the complex relationship of health problems. It's not just a person who has drug addiction and the individual, chose a lifestyle that led to drug use, and that's why they got Hep C. It's bigger than that. So there's different archetypes that we can use in public health, which are concepts to explain public health problems. And the one that applied most with hepatitis C was called shifting the burden. So it starts in the middle with the problem of Hep C infection. So we create a symptomatic solution, which is treating the virus. This can have a side effect of not focusing on the risk factors that led to it, disparities between those who have access to treatment and those who do not, and perpetuating stigma. When the real fundamental solution would be prevention of Hep C through reducing risk factors, treating substance use disorder, addressing mental health issues, increasing health literacy, and eliminating stigma. So this is the focus that could really help overall reducing hepatitis C. So hepatitis C, there are health disparities with 1% of the population having Hep C in the US. This goes up to 7 to 52% in those experiencing homelessness, and then even higher for those using injection drugs, 35 to 84% based on different studies that we reviewed. And the death rate from Hep C is higher in certain groups, even though they have lower population. So Native Americans have 3.5 times likelihood of death from Hep C, and Black people have 1.7 times the risk. And another interesting statistic from those who inject drugs is one person with Hep C who injects drugs can infect about 20 others within the first 3 years of infection. So treating one person and can prevent 20 other infections. So we want to treat Hep C to decrease all-cause mortality, to prevent advanced fibrosis and cirrhosis, and as a public health prevention, because there is no vaccine for hepatitis C because there are so many different genotypes. So we'll go into screening and diagnosis. A little review of some risk factors. Injection drug use, mainly, or drug use can be injection or non-injection, anything that's transferring infected blood, perinatal transmission, healthcare exposure with finger sticks, sexual encounters, contaminated needles with tattoos and piercings, sharing razors and toothbrushes, and in the 80s and 90s, different blood products and organ transplants weren't screened for Hep C, so some people acquired it that way. There are a lot of different screening recommendations from different bodies. The HCV guidelines is a combination from the American Association for Study of Liver Disease and Infectious Disease Society of America. They update hcvguidelines.org, which is a really great website as far as screening and up-to-date treatment. Also the USPSTF guidelines and CDC. So they vary slightly, but overall we condense the screening protocols here. Basically, all adults 18 or older, pregnant women should be tested during each pregnancy, and then one-time testing for those with HIV because when you have HIV or HCV, it's more likely to acquire the other one. Elevated ALT for unknown reason, prior transfusion or organ transplant in the 80s or 90s, any healthcare personnel with exposure, and children that are born to mothers with HCV. And then in persons who inject drugs or those on hemodialysis should be tested periodically. And this would even include if they're under 18, because they do have those risk factors. And then anyone who requests testing for Hep C should be able to get it without, question. So here we have a case study. Which of the following patients should be screened for Hep C? We have an 18-year-old female with a history of injection drug use, a 65-year-old male without complaints, but without previous Hep C testing, 72-year-old female with long-standing fatty liver and elevated LFTs, and for D, 26-year-old female on the second trimester of her third pregnancy, or is it E, all of the above? So it is all of the above. So we have the first patient has a history of injection drug use. The second patient hasn't been screened, even though he's 65. And he doesn't have any current risk factors. According to guidelines, everyone should be tested. 72-year-old female, we know she has fatty liver, but now her LFTs are elevated for unknown reason. And then during each pregnancy, regardless of risk factors, the women should be tested. So the range of symptoms for hepatitis C, when people first acquire the infection as acute Hep C, they could have no symptoms at all. They could have an acute viral illness or acute hepatitis with abdominal pain, nausea, vomiting, fever, chills, jaundice. Very rarely do they go into acute liver failure, but that is possible. As it turns to more chronic infection, people can just have vague symptoms such as fatigue. Over 10, 20 years can develop cirrhosis, and sometimes they present for complications of cirrhosis, like bleeding varices or confusion and hepatic encephalopathy, jaundice, and ascites, so fluid in the abdomen, and all the way up to liver failure. So we made a little diagram for diagnosis, which is pretty straightforward for Hep C, starting off with a Hep C antibody test. So has their body reacted to the hepatitis C virus? This can be done through, it's all with blood work, so either a lab draw or a finger stick for testing for the hep C antibody. If it's non-reactive, then there's no hep C. If it's reactive, then move on and check the HCV RNA, so the viral load, and reflex to a genotype, and that is a blood draw. So then you would get a positive viral load or a negative undetected viral load. So if it's negative, then they don't currently have an infection, and then you can retest as appropriate. So if this is a patient where you think they could have recently been in contact with hep C the past 2 to 4 weeks, wait a bit and retest the viral load. If they have ongoing risk factors, then maybe check them yearly or every so often. There's not clear guidelines on that. If there is a viral load, then they have hep C. They can be treated, and you assess the patient for their readiness to be treated. So here we have another case study. Cindy is a 37-year-old G2P2 female currently on buprenorphine for opioid use disorder who comes in for her annual physical. She had routine labs performed that were notable for an AST of 35, ALT of 50, platelets of 250. She does not know if she has had hep C screening, and there are no results on Health InfoNet. So what is the next step? So we were just talking about screening and testing. So is it hep C antibody, elastography, or vaccinating hep B? And that's going to be A. All of these might be done, but the first step is to check the antibody. And we're here. If someone has hepatitis C and we're gonna get ready to treat them, can start off with basic labs with the CMP, CBC, INR. If they're able to get pregnant, do pregnancy test, rule out co-infection with HIV and hepatitis B, and check the immune status of hep A and B. To assess for liver fibrosis, sometimes this is pretty straightforward, other times it can be a little complicated. There are online calculators that can help. The FIB4 index takes into account the age, the AST, ALT, and platelets, and gives a score that can assess from no fibrosis all the way to cirrhosis. Pharmacy uses the APRE score a lot, which is the ratio of the AST to platelet ratio. So similar to FIB4, but more focused on is there a possibility of cirrhosis or not. There's a FibroSure blood test that you can order, and it does its own calculation to give you a fibrosis number. Elastography is a special type of ultrasound that sends sound waves to the liver and it assesses for stiffness. So that can tell, is there damage over time? Has the liver started to become stiff? And are we going to cirrhosis? And of course, looking at your patient with signs of cirrhosis, do they have ascites, jaundice, asterixis? And you can also look at their labs as far as do they have thrombocytopenia, low platelets for unknown reason? What is their albumin and how has their liver been functioning? If you are able to determine if your patient has cirrhosis, next important step is to distinguish between compensated and decompensated. And this differentiation changes the hep C treatment. So compensated is going to be patients with the Child-Pugh score A. And this is another online calculator that you can do, and it assesses mortality risk. A lot of the times used for surgical risk in patients who have cirrhosis, but we also use it for telling overall survival and likelihood of developing complications. So you take into account ascites, bilirubin level, albumin, PTINR, and encephalopathy. So those are all things that we use in general to see if someone is decompensated. But just to give a perspective of class A, B, and C, for class A, there's 100% survival at 1 year. Class B is 80% survival at 1 year, and class C is only 45% survival at 1 year. So these patients are more fragile than those with child abuse score A. And I have some listed here as far as what decompensated is, which makes sense from how we're developing the scores. So if they have ascites or GI bleeding or encephalopathy, then they're decompensated and require a different approach to treatment. Here we have a case study. A 55-year-old female has chronic hep C, genotype 1b, viral load of 1.2 million, and is motivated to complete treatment. You ruled out co-infection and are assessing if she has cirrhosis. Your FIB-4 index says intermediate, use alternative assessment. I get this a lot of the time in practice. So what is the next step to determine if she has cirrhosis? So do you get an elastography to assess for advanced fibrosis or cirrhosis? Do you look for ascites, asterixis, or spider angiomas? Do you review all available imaging reports or all of the above? So that's going to take all of those things together to decide if she has cirrhosis or not. And getting ready for treatment. The most important part is, does the patient want to be treated at this time? Are they ready to commit to taking a medicine every day for 8 to 12 weeks or longer? And are they in the right frame of mind to do this treatment? And it's important to meet patients with cultural competence and be understanding of their beliefs, values, and culture. So this includes speaking in a respectful, non-judgmental manner, addressing and working on any personal biases, assessing their health literacy. How do they best understand and learn and use the healthcare information? And acknowledge that patients are dealing with a lot of other things that take priority over hep C treatment, especially if they're having no symptoms at all. So this could be staving off withdrawal, um, finding a job, maintaining transportation, and worrying about housing and childcare. All of these things are likely to creep up to the forefront than treating a virus that they may not be experiencing any symptoms. It also plays with helping to reduce stigma. So one important thing, which I've been trying to do throughout my practice in this lecture, is using person first language. So person experiencing homelessness, alcohol use disorder, individual with hep C, person in recovery, not using addict or homeless person, and just watching our words. And who qualifies for simplified treatment? So the hcvguidelines.org, we pulled this from here because treatment can be quite simple, choosing which medication if they meet this criteria. So people that don't have cirrhosis and they're not pregnant, because we don't treat hep C in pregnancy, if they have not had a liver transplant, there's not active hep B, they haven't been treated for hep C before, and they don't have liver cancer, they can be treated with simplified treatment. And that's also the same people who are compensated cirrhosis, so that Child-Pugh class A, they're doing fine, no complications. They also qualify for simplified treatment if they've never been decompensated before and they don't have end-stage renal disease.
Okay, so before deciding treatment, there's a couple things that you do want to look at. You want to see if if the patient is treatment naive. So this allows you to look into both medication options to see what may be best for your patient. You also want to look to see if the patient has been previously treated for hepatitis C. If they've been previously treated, what medication did they previously try, and go with the other available option. It also may be worth having a conversation with the patient about the previously trialed medication as well, to see if there were any barriers while taking the medication, whether it be side effects, cost, or anything that may have prevented them from being adherent with the medication that was previously trialed. These medications have a lot of drug interactions as well, so looking at the current med list before deciding treatment is really important to make sure that there's not going to be any interactions, and decreasing how the medication works. And then some of these medications do require to be taken with food. So here's another opportunity to talk with your patient and have a conversation to see if food insecurity is a barrier, because then this will decide what medication is best for your patient. So here is med selection for treatment naive. So again, you want to look to see if the patient has cirrhosis. If they do have cirrhosis, you then want to look to see if they are compensated or decompensated, or even if it's unclear. If they are compensated, you can go ahead and treat with Mavorite for 8 weeks or Epclusa for 12 weeks. If they are decompensated, you want to refer to a specialist for a consult. If they don't have cirrhosis, you want to look to see, do they qualify for simplified treatment, as Nikki spoke about earlier. If they do, then again, you can go ahead and treat with Mavorite or Epclusa based on the patient that you are treating. And if they don't qualify for simplified treatment, then that's when you would also want to refer to a specialist for consult. And here is the pathogenesis of hepatitis C. Highlighted in the red boxes are where the drug targets within the life cycle of hepatitis C. So the three main targets are NS3, NS5A, and NS5B. The NS proteins are essential for replication, and the drugs that target these sites have the ability to inhibit HCV. So moving on into treatment options, we have Mavorite. Mavorite is an NS3/4A protease inhibitor as well as an NS5A inhibitor. Dosing is 100 milligrams per 40 milligrams, and the patient would take 3 tablets once daily for 8 weeks. Each box comes with the 3 tablets, as you can see in the picture below. So it is easier for the patient to have all three medication within the same box. Adverse effects the patient may experience more commonly are fatigue, nausea, headache, and diarrhea. If the patient is experiencing any of these side effects, there are medications that the patient can take if the side effects are bothersome. But again, it's important to look for drug interactions first. But for example, if the patient was experiencing diarrhea, it would be safe to recommend Imodium, but to limit the use to 48 hours to manage the diarrhea. And then it's always important to go over patient counseling points for every time the patient is filling this medication, either for the 8 weeks or the 12 weeks. So it's important to let the patient know to take the medication with food and a full glass of water, especially with Mavorite. It's important to take all 3 tablets at once and to take them at the same time every day. I typically tell patients to take it with the biggest meal of the day, so typically at dinner time, to avoid the GI upset and the side effects that they may experience. It's important to not skip doses or stop the medication early. If you do miss a dose, take it as soon as possible, but if it's too close to your next dose, skip that dose. But that is important to let the patient know that it is going to extend their treatment. And then you also want to avoid grapefruit juice and St. John's wort. The next treatment option is Epclusa. This is a NS5A inhibitor and an NS5B polymerase inhibitor. The dosing is 400 milligrams per 100 milligrams, and this is where a patient would take 1 tablet by mouth once daily, but for 12 weeks instead of the 8 weeks. So therapy is a little bit longer. So that's important to keep in mind for whoever you're working with. Um, and adverse effects that a patient may experience is fatigue, nausea, headache, nasal drip congestion, and sore throat, and insomnia. And again, with patient counseling, pretty similar with Mavorite. One thing that I would like to point out that's really important is that um, you can take it with or without food, but if you do experience side effects, you can take it with food to lessen the GI effects that a patient may be experiencing. If patients are on famotidine, they may take it simultaneously with Epclusa, or they can separate it by 12 hours. Antacids should be taken 4 hours apart from Epclusa, and PPIs are not recommended while taking Epclusa, so they should be avoided entirely during treatment time. So if a patient is on PPIs, Epclusa may not be the best option, and other options are available. And then you also want to let the patient know to avoid alcohol while on these medications. And the third treatment option is Vosevi. You typically see Vosevi if they have previously been treated on Epclusa, then they can use Vosevi for another treatment. So this is an NS5A inhibitor and an N534A inhibitor and an NS5B polymerase inhibitor. So it's Epclusa plus and the dosing is relatively similar. It's the 400 milligrams per 100 once daily, again for the 12 weeks. And adverse effects are headache, fatigue, diarrhea, and nausea. And patient counseling points very similar with the antacids within the 4 hours before, 4 hours after taking Vosevi. And then it's important to store in the original container. And with this medication, similar with Mavyret, it is important to take this medication with food. Okay. So going on to the efficacy of the three medications that I just went over and comparing it with Pegasus. Pegasus was a treatment for hepatitis C, and there were a lot of side effects with it. So there may be some hesitancy with the new treatment options. So I want to take a minute to just to highlight the differences between the efficacies of the medications and the adverse events that are most commonly seen and percent rates that have been seen. So to start off with Pegasus, there is a black box warning. The warning was aggravated or fatal or life threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders. These warnings did require a lot of monitoring in the patients periodically with lab evaluations. And most likely it was seen if therapy was withdrawn, then these symptoms would resolve, but not always. So it was important to keep that in mind. And then there were also 3 studies of monotherapy Pegasus to show the response rate of sustained response to the monotherapy. One study showed that there was a 24% response rate. Study 2 showed a 35 response rate, and study 3 showed a 23 response rate. So with the newer therapies, as I've mentioned before, the side effects are pretty more tolerable than Pegasus. So again, the most common with Mavyret was greater than 10% of subjects experiencing headache and fatigue. And then it shows a 98% cure rate in treatment with naive patients. A 96% of patients were virally suppressed at treatment week 4, and 100% cure rate with a less than 90% adherence rate. For Epclusa, similar, there was only a report of patients experiencing headache, fatigue, nausea, asthenia, and insomnia with a 98% overall cure rate in clinical trials, a 99% overall cure rate in real world integrated analysis. And then Epclusa did also demonstrate cure in people who inject drugs, including those receiving MAT, and showed a 94% overall cure rate as well as 100% overall cure rate. And for Fosevi, most adverse side effects in the simplified trial were fatigue, nausea, and headache, and adverse reactions leading to permanent discontinuation of treatment were not observed in any patients. And there was a 96 to 97% of patients who received Osevi had no virus detected in the blood 12 weeks after finishing treatment, suggesting that patient's infection has been cured. So it's really important to emphasize how safe these medications are and how important it is to treat patients with these medications. Okay, so we have another example case study. So Pat is a 62-year-old male who comes in for an acute visit due to abdominal swelling. On physical exam, you notice icteric sclera, tense and distended abdomen, and asterixis or hand flapping. There are spider angiomas on his chest and neck. If he had chronic hep C, how would you proceed with treatment? A, you would start with sofosbuvir or velpatasvir for 12 weeks. Patient has decompensated cirrhosis and refer to GI or hepatology. Or C, refer to infectious disease. And the answer is B, patient has decompensated cirrhosis and you would want to refer them to GI. This patient has several indications of decompensated cirrhosis, including the tense and distended abdomen, which can be indicative of ascites. So you would want to, any patient who presents as decompensated would be referred to a specialist. And monitoring during treatment and after treatment. So during treatment, you want to monitor for hypoglycemia for patients with diabetes. And for those on warfarin, you would want to monitor the INR because these medications being used concurrently with warfarin may decrease the INR, so dose adjustments may be necessary. And then you also want to look out for co-infection with Hep B, and that includes getting an AST and ALT if anti-HBC positive only. And after treatment, you want to check Hep C viral load and hepatic function panel 12 weeks after treatment has been completed. And if a patient does have ongoing risk, then you would want to check the viral load yearly. And these are the vaccine options for patients. So there is a risk of hepatitis B reactivation in patients co-infected with Hep C or Hep B. So you want to make sure that you test all the patients before initiating treatment. So the vaccine options are Havrix, which is the hepatitis A, and then you also have Twinrix, which is the Hep B and Hep A, and then the hepatitis B and Jarix B vaccine. These are all 1 ml doses. Um, for Hep A, there are 2 total doses administered at 0 and 6 months. Hep B, there are 3 total doses at 0, 1, and 6 months, as well as the Twinrix, the 3 doses at 0, 1, and 6 months. Common vaccine adverse reactions that you would want to counsel the patient on are headache, fatigue, and soreness or redness at the injection site. And now going into the example hepatitis C treatment protocol. A protocol is in place for pharmacists to follow when a consult is initiated for a patient with hepatitis C. Providers may initiate a pharmacy consult where pharmacists will look more into patient's medical record to decide if they are treatment ready or need anything further before initiating treatment. So the first step is labs. You want to get a viral load, like Nikki has mentioned earlier, and also a genotype. You also want to get the Hep B status and a Hep A status. So with Hep B, you get a Hep B panel, and then you can interpret that to see which vaccine they would be eligible for if they are eligible for a vaccine before initiating treatment. And to determine Hep A status, you can check Health InfoNet, Impact, or based on patient's narrative. You also want to get a CMP, an INR, and a CBC within 3 to 6 months. It's easier to get all of these drawn at once because it is a blood draw. And you would also want to get an HIV panel. So step 2 is to check FIB4 and the APRE score to determine cirrhosis. So the FIB4, as Nikki had talked about earlier, this includes age, AST, ALT, and platelet count. And on the right side, you can see it gives us ranges to say if they have no cirrhosis or if they should order a FibroSure. or if it indicates cirrhosis and needs to be referred to GI. And then we have the fibrosis staging from F0 to F4. And then the APRE score, this does not have ALT incorporated into the calculation. It just has AST and then whatever your facility's upper limit of normal AST is. And that may vary from facility to facility that you're at. And then it takes into account platelet count as well. And then it also gives you a range for no cirrhosis, order fibrosure, or refer to GI or ID. So step 3 would be vaccination. So if you look at HIN impact or the patient's narrative, all indicate no history of Hep A vaccination. You want to offer the vaccination. Um, so the patient also may decline, and that's fine, but you just want to make sure to document the patient declining the vaccine. And here is just a chart based on the Hep B panel. This shows examples of possible results from a patient's hepatitis B panel. This helps interpret whether the patient has an acute or chronic infection, immune due to previously being vaccinated, or if they are susceptible, and allows us to determine whether to vaccinate the patient or not. And then again, so if a patient was immune to Hep B and not A, then you would want to order Havrix. Immune to Hep A and not B, then you would do Engerix. Not immune to either Hep A or B, then you could do Twinrix in the 1 ml dose rather than doing 2 separate vaccines. And then if a patient presents with cirrhosis and are considered F4, then you would want to get a pneumococcal vaccine. And step 4 would be to start treatment. So without cirrhosis, you can do the Mavyret for 8 weeks or Epclusa for 12 weeks. And with compensated, again, you can do Mavyret or Epclusa, but you want to make sure that if they are decompensated, that's when you would be referring. And step 5, you would do on treatment monitoring. So for follow up, you would want to look at liver enzymes every 4 weeks while on treatment. You want to make sure you're following up by phone call every 2, 4, 8, and 12 weeks, depending on chosen therapy. And you can schedule and order post therapy labs once they are finished treatment. Step 6 is post treatment monitoring. So, again, 12 weeks after therapy is complete, you want to get a viral load again and to determine a cure. And if failed to achieve SVR, then you want to refer to a specialist. And then again, yearly, you want to get a viral load, especially if there is a patient that has ongoing risk for HCV infection or develops elevated liver enzymes or bilirubin. And then just for decompensated cirrhosis, you must refer to GI. And Nikki had previously talked about some of these. So, current or prior episode of decompensated cirrhosis, HIV positive, end stage renal disease, prior Hep C treatment, known or susceptible hepatocellular carcinoma, or prior liver transplant. To conclude, chronic hepatitis C is prevalent in Maine. Every patient should be screened for hepatitis C at least once. Current treatments are very effective and well tolerated. Most patients qualify for simplified treatment and can be treated within primary care settings. And these are our references. And key takeaways is to test everyone at least once and treat accordingly. And for any questions, please email Nikki and I, and we would be happy to answer any questions.
Thank you.
Thank you.